what we do every morning is to have a kickoff meeting, call it our morning meeting, and just spend a few minutes usually talking about a topic of interest. Today, actually March 3rd is triple negative breast cancer awareness day. And I just thought, to honor that day, we would just quickly review a few of sort of the ins and outs for patients with triple negative breast cancer, because it's a huge unmet medical need. When we talk about triple negative, what we're talking about is sort of the classic three markers for breast cancer. Those are estrogen receptor, progesterone receptor, and something called HER2. And that's usually amplification. The estrogens are hormones, and they drive the growth and division of cells normally in the body. Cancer sometimes uses those same signals to drive their own growth. And when they are present, you can then use the anti-hormonal agents to block them. However, in triple negative breast cancer, you don't have that. And so what you're left with is really no handle in the usual way that we attack breast cancer cells. So what that leaves us with is really the old standard chemotherapy. And where triple negative breast cancer has been going recently is that they have been figuring out that immunotherapy, which again works amazingly well in melanoma and lung cancer, that it also works in triple negative breast cancer. And so for the first time, we have a bit more of a handle on that. So what I want to just do here is showcase a little bit, and these guys will show you more later, but I'm sharing my screen. And for patients with triple negative breast cancer, if they have local disease or regional, something that they think, the doctors think can be removed surgically at some point in time, it's really important to get therapy before surgery, because there's so many reasons. But one of the primary reasons is to actually see how the tumor responds to that therapy, whether they can really shrink it down so that they know in case it comes back later, they've got something that they can use again. For patients who have metastatic disease, which is it's spread beyond the local area and is in a distant organ, the lung, the liver, could go to the brain, then those principles won't really apply. Surgery is not really going to be an option. So for those patients who are obviously at quite high risk, we would encourage, because there is sort of the standard chemotherapy, sort of old-fashioned, lose your hair, get nauseous and vomit sort of chemotherapy. But there's a lot of new therapies, and those new therapies can be found on clinical trials. And what I'm showing here is just a quick search that I did in sort of honor of triple negative breast cancer to see sort of what's out there. And as you can see, this is focused on what we call first line therapy. So these are patients who are newly diagnosed with metastatic breast cancer, and there are actually 21 matches that came up across the United States, which is actually a pretty high number for first line therapy. When you look at these, there's some really exciting combinations. There is ones that have chemo plus something new. There are ones that are studying something completely new, and includes a comparison to chemotherapy, and yet there are yet others that have what we call antibody drug conjugates. Some are really new class of therapies that's coming down the pike and is getting approved more and more. And then there are also ways of looking at combining, like this one, where we're looking at combining immunotherapy in new ways with sort of the standard of care or with new agents. And so there's really quite a variety of this. And when I look at the map of the United States, you could see that as I zoom in here a bit, that really, the vast majority of the United States is covered with at least one option. And so I think it's fairly realistic to expect that most triple negative breast cancer patients, they have metastatic disease, will be able to find a trial that will give them the hopes of doing better and having less toxicity than the standard of care. And so that's sort of the premise that's out there. Now, for patients who have triple negative breast cancer and they've already been treated, what do? Well, I will load up another search that I did for what we call second or third line. these are patients who have gotten, let's say, the standard of care and are, and need something more. And here you could see actually the number of trials increase, and 65 across the United States, looking specifically for triple negative breast cancer. And again, they represent all of those same sort of exciting, innovative approaches. In addition to that, there are things like CAR T therapy that I pulled out somewhere along in here. There's combinations that are, again, trying to do better for patients. And so again, with this number of possibilities, we again look across the United States, and you could see that, that once again, the expectation is that, no matter where a patient lives, let's say they're in the Boston area, which is where we are, there's going to be multiple options within reach for them. And then finally, I'd say I would just leave, you guys, as and everyone else out there, on a note that says, hey, if you have triple negative breast cancer, there's one sort of test diagnostic that is going to be very valuable. Does anyone in the room know what I'm thinking of here? A diagnostic test that's going to be really valuable for triple negative breast cancer patients. You have until this thing stops. Jay, Julia.
Blank over here.
Any ideas? We do it all the time for cancer patients when they're at high risk.
Tumor sequencing.
Ah, yes. Tumor sequencing. So that's the one diagnostic that I'd say every cancer patient at high risk needs. And again, there's no doubt that triple negative breast cancer is among that group. And what happens is when you do that test, this is a nice thing. I didn't actually point out, but in the other searches, there were something like 8 genes listed or 10 diagnostics listed. But when you add in the genetic analysis of the tumor done by next-gen tumor sequencing, those options then expand incredibly, right? And so instead of looking at 20 or 60 possible options, we're now looking at 517. And again, we can look at all of the genes, but basically, any of these genes that come up in the next-gen sequencing is going to likely have a match amongst this hundreds of genes that are listed here. And so, from my perspective, that's where, the hope really springs eternal, because, we have a great success when we match patients to those specific precision medicine avenues of treatment. They do better. Patients do better. And we can really convert this into a long-term success.